WeInfuse Podcast, episode number 46. Welcome to the WeInfuse Podcast. My name is Amanda Brummett. In every episode, we give you a seat at the table as we talk to infusion center owners, operators, and experts so that you can get the insight you need to run a thriving practice. In this episode, we talk with Chuck DiTrapano, founder and vice president of pharmacy education with Rx Toolkit. We'll get a snapshot into Chuck's fascinating journey into medication safety, learn why he had to be part of the solution, and get insight into how Rx Toolkit saves lives. As I shared, I'm super excited to be here today with Chuck DiTrapano from Rx Toolkit. Thank you so much for being here, Chuck.
Thank you. I'm glad to be here.
Yeah, so I absolutely wanted to get into how you've made medication administration safer for both patients and caregivers. But before we get into that, can you give our listeners a snapshot of your professional background prior to creating Rx Toolkit?
Sure. I'm a graduate of the Albany College of Pharmacy in Albany, New York, which is my hometown. Right after graduating pharmacy school, I was during Vietnam. And I ended up joining the New York National Guard as an Army medic. I went to military high school, so I'd always wanted to be an officer in the military. So one day I decided to join the United States Navy. I got a direct commission as a lieutenant and became a pharmacy officer. My initial duty station was in Bethesda, Maryland. And then from there, I went to Philadelphia, Pennsylvania. The duties of a hospital pharmacist in the Navy are similar to the duties of a civilian pharmacist as a hospital pharmacist, although we had a very large outpatient setting as well as an inpatient setting. Got involved in the infusion therapy actually there when infusion therapies by pharmacy were relatively new. Many of the IVs were not being mixed by pharmacy in those days. Subsequent to that, I left the Navy and held various jobs in various career positions and ended up becoming an executive of several large pharmacy organizations, primarily devoted to institutional pharmacy, which is nursing home pharmacy. I became a vice president at a company called Vitalink, which was a national company, and I was vice president of operations for them. And then they were subsequently acquired. And I went to work for Omnicare, which is the largest provider of institutional pharmacies, which is now owned by CVS, and became in charge of I was a vice president in charge of their assisted living division. By then, I had spent maybe 15 years not practicing as a pharmacy. And quite honestly, I missed the profession. I missed being a pharmacist. So I up and quit my job, moved back to Pennsylvania, where my home was, from actually from the Navy. And joined Reading Hospital as a hospital pharmacy supervisor, which was in 2001. Immediately became aware of the difficulties pharmacists have with keeping up with all the different technology and content. You know, if you walk around a hospital, you'll see people with notepads and index cards and binders. And so I decided that I went to my boss one day. And I said, how do you know what people are doing? How do you know that pharmacist A is making the same clinical decision as pharmacist B when it's relevant to a certain patient condition? And I said, I think I can fix that. So the first thing I did is I actually created a paper binder. I gathered content we had about 40 pharmacists at the time, and I gathered content from as many as I could, put it into a paper binder. It was about a 3 or 4 inch binder. And then said, there's probably a better way to do this than making it a binder. And my partner, who's my partner now, John Neville, was the CIO for Rx Toolkit, I called him up and I asked him, I said, I would like to be able to basically consolidate information into a place where people could search it and everybody would be working off the same sheet of music. So him and I got together, we designed the beginnings of Rx Toolkit. I presented it to my boss at Reading Hospital, and we launched it maybe 8 months later. So that's how it got to where I am today, I guess.
That is amazing. Don't you feel like every good story starts with, I up and quit my job?
Yeah, I took a pay cut, probably 2/3. I mean,
Ouch.
It was, but it was funny because one of my colleagues at Omnicare, who was a clinical pharmacist, he used to call me clinically dead because I didn't know anything anymore. I hadn't really practiced and I can tell you that when I graduated pharmacy school, the drugs that are available today, probably 95% of them didn't exist back then. So, any healthcare position is a continuous learning process. You can't and I assume that that's the same with any condition, with any profession. And so I wanted to be able to survive. And by building the binder and then subsequently creating Rx Toolkit, I was educating myself at the same time as I was providing a resource. It was a survival process for me, because you sometimes are put into situations where you need to be able to have information, accurate information, to be able to do what you need to do for the patient.
Absolutely. Well, I understand that you have a really impactful story around patient safety and NICU saves. Can you talk about that and how it ultimately ended up with you creating Rx Toolkit?
Well, there was a story going around about a young girl, a 2-year-old girl in Cleveland, who died as a result of a medication error. And I had a near miss. A near miss is when a medication error doesn't reach the patient. It was a very busy day. And I was checking IVs, and I had a whole, you have a timeline to get the IVs checked by because everybody has to go out and deliver them. And I had this big stack of IVs, and I was checking them. And I always used my entire career, I used the blue Sharpie and put my signature was a C with a blue Sharpie. And I kept checking all these IVs. And for whatever reason, I checked one, put it into the checked pile. And then like 2 checks later, I thought, wait a minute, that wasn't right. And I brought it back. And it turned out that it was incorrect. And that really scared, it could have been a really serious medication error. And it really scared me. So I began to research more about the story around this little girl whose name was Emily Jerry. And as I researched it, I found out that the pharmacist who made the error was in a similar situation as I was. He was being, the pharmacy computer system had been down. It was like one of those perfect storms. He had a timeline. People were calling him, where's my IV? He went through the process, and a technician had run out of of normal saline, which is a diluent that they use for IVs, and decided to make her own. But she made it using concentrated sodium chloride, 23.4%, but didn't dilute it. Eric didn't catch that error that the technician made. And subsequently, that drug was administered to Emily, and Emily died as a result of that. Eric ended up going to jail. There's a whole story behind the scenario, but he ended up going to jail, serving hard time. And I was aware of that and thought, but for the grace of God, go I, sort of thing. And I decided I really wanted to talk to him to understand his experience. So I knew that a fellow by the name of Mike Cohen, who's the president of the Institute of Safe Medication Practices, was a friend of mine. And I asked him if he could get a hold of Eric for me. And so long story short, I got a hold of Eric. I invited Eric to come to Reading Hospital primarily to speak to my department. By then I was the operations manager. I was in charge of pharmacy operations. And I said, could you come down and speak to my staff? Well, it turned out that when the hospital got wind of it, they actually opened the doors and he spoke to multiple disciplines. He actually made several presentations. And Eric's story was very compelling. And so I learned from that it can be very harmful to the second victim of a medication error, which is the caregiver. All of us that are in the profession got into the profession because we wanted to do good. The last thing we wanted to do is harm anybody, and it's devastating. And if you look at it, there are reports in the literature of people going as far as committing suicide when they've made a catastrophic medication error. So that put me on the path to say, I really want to do something to help myself and my colleagues prevent these errors from occurring.
Right. And then I know yeah, absolutely. I know that it's more complex than a quick answer, but can you give us the overview of how Rx Toolkit does that, how it protects both the patient and the caregiver?
Well, I'll give you a little history of how we got started. As I mentioned, we began in 2004. We launched in June of 2004. And we were basically a catalog of content, of procedure manual primarily, but some drug information, but how that drug was used. If you think about, how a drug is used, it may be used in the neonatal intensive care completely different than how it's used in intensive care, and completely different in how it's used on a cardiac unit in terms of the parameters and dosages and things like that. So we compiled that and segregated it into care settings. And then we actually won the Institute of Safe Medication Practices Cheers Award that year for innovations in medication safety, because in 2004, the internet wasn't anything like it is today. And come 2005, and up until then, we were just basically a content provider. We had search tools and the like. In 2005, the Joint Commission on Accreditation of Hospitals put out a standard that said that pediatric and NICU IVs had to be standardized. Up until then, most practices used what's termed as the rule of sixes. The rule of sixes makes it very easy, and drugs are typically weight-based. So the rule of sixes makes it very easy for a clinician to prescribe and for a nurse to titrate. But that means every day the pharmacy has to make a different concentration. So on one day, it's this much dopamine and D5W, and the next day it's a little bit different, because in these little infants and children, their weights change on a daily basis. And in a neonatal intensive care, as an example, it can change significantly in terms of a percentage of overall weight. So the hospital was faced with a dilemma, and they wanted to be able to standardize it. So the head of the patient safety team came to me and said, is there anything you could think about doing that would help us? And we built an application that is still in use today, and this is 2005, to standardize the administration of neonatal intensive care so that the pharmacy always made the same, but we gave the clinician at the bedside the tools to be able to understand how to titrate it. So if you want 1 milligram per kilogram per minute, this is what you do. If you want 2 milligram per or 2 microgram per kilogram per minute, this is what you do. That kind of thing. That put us on the road of building apps. We changed from a content provider to a resource tool. And over the years, we built, I believe, 22 different applications, not all clinical. Some are, we're non-clinical, but all of the neonatal intensive care products and pediatric products that are in the system that we built are still in use today at Reading Hospital. And we have two saves. A physician was woken up 3 o'clock in the morning, was asked to prescribe a infusion concentration for a baby, made an error, a multiple fold error. The pharmacist who checked it put it through Rx Toolkit. Rx Toolkit recognized the error. The pharmacist called the supervisor on call because it was like 3 o'clock in the morning, and the supervisor on call confirmed it by logging into Rx Toolkit and doing the same thing. And we prevented that error from happening or ever reaching the patient. In another instance, we provide, if you think about a crash cart, and a crash cart can have a significant number of drugs. When you're dealing with an infant that might be, less than 1 kilogram, the dosing has to be extremely precise. And we built a tool where we took every drug in the entire crash cart, and we allowed the user to put the patient's weight in. We actually maintain the patient's weight. So every day, every time a new NICU baby is born, that document has to be, by policy, has to be presented and put on the chart so that if that baby does crash, all the doses are calculated, including right down to the milliliter, in terms of how many, what the volume would be. What had happened is that we used a kit for a drug called adenosine, and the kit was stocked incorrectly. And as a result, the NICU nurse, when presented with the dose that she was to be administered based on the sheet, looked at the kit and said, wait a minute, this concentration isn't the same as what this sheet says, and went and got another kit and administered the correct amount. So that's two that we know of.
That's incredible. So you mentioned the Institute for Safe Medication Practices Cheers Award for Medication Safety. Can you tell us a little bit more about that?
Well, they still have that. Mike Cohen established this organization. It's based out of Philadelphia. Mike was the director of pharmacy at Temple University Hospital when I first met him. And it's a nationally recognized resource for medication safety practices. And they offer each year about 3 or 4 awards in different categories. And the one that we won was for technological innovation towards medication safety. So John and I went down to Florida at the time and received the award. It's sitting on my shelf over here.
Congratulations.
Yeah. Thank you.
And I understand that Rx Toolkit recently became a WeInfuse company. I'm curious why you chose to partner with WeInfuse.
Well, I left Reading Hospital in 2017 with the intent of marketing Rx Toolkit to hospitals. So we were in the process of doing that. And one day out of the blue, I get a call from this fellow named Brian Johnson. And he said, one of the things that we developed, one of those apps that we developed was a whole labeling system, repackaging system for hospitals. And he called me and said, I've seen some of your labels online. I'd like to learn more about them. So that was in 2017. That was my introduction to the WeInfuse folks. And I don't know, you sometimes meet people that you just feel like you want to know better. And so over the years, we've exchanged, there were times when they would refer business to us or they would ask us questions. And, we never really had a formal relationship in terms of, a business relationship. But we always consulted one another. One of their nurses would often, when they worked, would call us and, tell us, go talk to this company because they need some help. And so it introduced us to the infusion center market, and we started to grow in the infusion center market with a lot of it with, seed referrals from the WeInfuse folks. We got to meet them when we went to the NICA convention, National Infusion Center Association meeting in Austin in 2019, I guess, and just always felt really comfortable with them. And then one day Reese called me up and said, you know what? We think we might be able to do something together. So that was that. And my wife and I always said, if there were a company that we would ever want to partner with, it would have been them. So I didn't tell Reese that until after the negotiations, but it was just, they were people that I wanted to work with because I felt that our philosophies about business were aligned. Our approach to customer satisfaction and customer service were aligned. Our innovation to think out of the box and do things differently was aligned. And I learned those things about them just interacting with them. And I thought, this could be synergistic. So it was an easy decision on my part.
The great stories that don't start with, I up and quit my job, do start with, I got a call from Brian or Reese.
Yeah, exactly. I was fortunate enough to have both those things happen.
Speaking of that, can you share some people?
I was just going to say that I was just down in Dallas. And the one thing that I do want to mention is that you have a perception of what things are going to be like. And then when you get there and you see it, it's better than I thought. The exuberance, the youthfulness, I just had breakfast with a neighbor of mine this morning. And I said, I went down there and I saw some of the smartest, most innovative, creative people, compassionate. It was very helpful to me to be around such a wonderful group of people.
Totally agree. They get me fired up every time I talk to them.
Yeah. They're and our client success person is a young lady by the name of Kiana Dietz, and boy, is she, I couldn't have asked for a better person to represent the company. And so I'm very excited about what the future holds for all of us.
Fantastic. So you mentioned a lot of names along the way. Is there anybody else that's been instrumental on your journey that you want to tell us about?
My dad was an immigrant, 6th grade education, came to this country without any knowing the language, and just inspired me to, that there's nothing you can't do if you're given the opportunity. And so you need to seize upon it. My brother was 10 years older than me, you never back down. So he was a very inspirational person to me. I lost him, but I'm still very close to his children and my wife. My wife, Deb, has just been a rock, so it's those are the 3 most important people I think that have influenced me through my life up to this point in terms of, quitting your job is scary, but if you have somebody, you got to be able to do what you got to do sometimes. So if it just feels right.
Absolutely.
Mm-hmm.
So my last question for you, and it's twofold, is your last piece of advice. And I would say both to our listeners who are mainly owners and operators of infusion centers, but then secondarily, based on some of the stuff you've shared, any advice for clinicians out there, especially as, they potentially are that second victim in the medication error. So advice to both our listeners and clinicians.
Rx Toolkit is built around the drug. And to me, it's you got to know the drug, and you got to know the drug and how it's used in your clinical practice setting. And don't assume anything. And there's a reason why pilots have checklists. If a pilot's been taken off and, up and down multiple times, they still do that checklist before they take off. And I think there's a reason for that. And, don't ever make the assumption that you've got this without, just refreshing yourself. And the other thing is, if learn from your mistakes, learn from the errors, learn from the near misses. Don't submerge them, don't push them underground. It's the only way people will learn best practices, is to be able to, learn from the errors and constantly reevaluate your process, and include the people that are doing it. I've always believed that the people that are at the front end, at the front lines, really have the best information in terms of how to get, where the pitfalls are. So those are the things that, I've always tried to implement in my career.
Well, Chuck, thank you for all that you've given back to medicine, to caregivers, to patients, and thank you for being part of WeInfuse and for bringing Rx Toolkit to everyone.
I'm excited, really excited. I feel 20 years old again.
What a great story. Chuck is not one to brag, but it's truly inspiring how he took the initiative to create a safer place both for patients and clinicians in infusion centers, hospitals, and everywhere medications are administered. Well, if you haven't done so already, do yourself a favor and give the WeInfuse software platform a test drive to see how it can save you time and money in your practice. And while you're at it, be sure to ask the WeInfuse team about Rx Toolkit. My name is Amanda Brummett, and we'll catch you in the next episode.